When a liver fails, we're not just looking at a localized organ injury. The entire hemodynamic and biochemical equilibrium of the body basically collapses. It's a massive, systemic, multi-axis failure cascade. So let's jump right into this explainer and systematically break down the altered hemodynamics of cirrhosis. We're going to calibrate our clinical lens strictly for a top-tier understanding of these lethal complications.
All right, let's start with the primary mechanical driver here, portal hypertension. As chronic hepatic injuries stimulates fibrosis, the liver's architecture becomes rigidly distorted, and this fibrotic resistance creates a massive pressure bottleneck. I mean, the blood has to go somewhere, right? So it's forcefully shunted away from the liver and driven right into delicate portosystemic anastomoses. This high-pressure splanchnic shunt leads directly to the engorgement of thin-walled, incredibly fragile esophageal varices. You have to remember, these vessels were absolutely never designed to handle systemic-level pressures. It makes them a literal ticking time bomb for catastrophic hemorrhage.
Now, what's truly fascinating is the absolute dichotomy in how we manage these varices, completely depending on the patient's clinical state. To prevent that first life-threatening bleed, we rely on the prophylactic mandate. We're talking non-selective beta blockers, specifically Nadodol or propranolol. By blocking beta-2 vasodilation, we allow for unopposed alpha-1-mediated splanchnic vasoconstriction. This effectively clamps down the inflow and drastically drops those portal pressures. But contrast this directly with the active bleed protocol. If your patient is actively hemorrhaging and in hypovolemic shock, beta blockers are strictly contraindicated. No way. They would completely eliminate the patient's compensatory tachycardic response. Instead, the absolute medical mandate shifts to IV octreotide. It's a somatostatin analog that rapidly shuts down splanchnic blood flow, acting strictly as a medical bridge so you can get them to emergent endoscopic band levation.
So this mechanical failure quickly cascades into the neurological domain. Hepatic encephalopathy isn't just clinical confusion, you guys. It's a profound biochemical crisis driven by toxic ammonia kinetics. Here's how it plays out. Step 1, the failing shunted liver totally loses its ability to clear ammonia, or NH3, from the portal circulation. Step 2, this highly lipid-soluble NH3 freely crosses right over the blood-brain barrier. Step 3, once inside the brain, astrocytes desperately attempt to detoxify the ammonia by converting it into glutamine. And finally, step 4, glutamine is heavily osmotically active. As it accumulates, it draws massive amounts of water into the cells, driving severe astrocytic swelling. This cerebral edema disrupts normal neurotransmission, giving us that classic physical exam finding of asterexis, that flapping tremor of the hands.
Once you understand those kinetics, the exact pharmacological targets become incredibly obvious. Lactulose is our absolute first-line therapy. Interestingly enough, it doesn't work just by increasing bowel movements. Its primary job is to strictly acidify the colonic lumen. This acidic environment forcefully converts that absorbable, toxic NH3 into non-absorbable NH4+, effectively trapping it right there in the gut for fecal excretion. On the other side of this matrix, we have rifaximin. This is strictly a non-absorbable antibiotic. We're adding it to the regimen for refractory cases to directly eradicate the urea-producing gut flora, the actual bacteria generating the ammonia in the first place.
But here's the thing. Treating the symptom is completely insufficient if you miss the underlying trigger. We have to isolate the clinical variance between primary and secondary encephalopathy. Primary encephalopathy is simply the result of end-stage advancing liver disease. But secondary encephalopathy, it presents identically, but it's triggered by a discrete, acute stressor. You must aggressively hunt for the precipitant. Is it a GI bleed, delivering a massive protein load into the gut? Is it an acute infection, like spontaneous bacterial peritonitis or SBP? Or maybe it's a metabolic derangement, like hypokalemia, which directly accelerates renal ammoniogenesis. Identifying that precipitant is absolutely just as mandatory as giving them lactulose.
Well, we see a very similar systemic cascade when we examine cirrhotic ascites. And this brings us to the vasodilatory paradox. As severe portal hypertension progresses, it drives massive local shear stress, leading to the systemic release of nitric oxide. This causes profound, inappropriate splanchnic vasodilation. Because so much blood is pooling in that splanchnic bed, the kidneys sense a critical drop in effective arterial blood volume. Believing the body is bleeding out or severely dehydrated, the kidneys aggressively activate the renin-angiotensin-aldosterone system, or ROS. They start retaining massive amounts of sodium and water. This excess fluid continuously weeps from the engorged hepatic sinusoids directly into the peritoneal cavity.
To combat this intense RAS activation, discrete management steps dictate a strict dual-axis pharmacological blockade. You really can't just throw a loop diuretic at this. You must deploy spironolactone as the foundational therapy to directly block the massive pathological aldosterone surge that's acting on the distal tubules. Then furosemide is added secondarily to block the sodium-potassium chloride transporter in the loop of Henle, which enhances the fluid pull. Managing this diuretic matrix requires precise balancing. You want to mobilize that fluid, for sure, but without crashing the patient's intravascular volume. And when diuretics fail, we turn to mechanical fluid removal, which introduces a really severe clinical trap. Why does large volume paracentesis, meaning removing more than 5 liters of acidic fluid, carry an absolute mandate for simultaneous IV albumin administration? Well, because draining that massive volume drops intra-abdominal pressure instantly. The splanchnic vessels, which were previously compressed by the 10 ascites, suddenly dilate further, causing massive venous pooling. This instantly exacerbates the effect of arterial hypovolemia, basically starving the kidneys of perfusion. So IV albumin is strictly mandated to expand the intravascular volume and prevent fatal post-paracentesis circulatory dysfunction and acute hepatorenal syndrome. Okay, let's put all of this together into a master case that demands some really deep integration. Consider this patient profile. We have a 58-year-old cirrhotic male presenting with profound confusion, disorientation, and bilateral asterixis. His labs showed distinctly elevated ammonia levels. Looking at his history, we note that 4 days ago, his physician doubled his furosemide dose to strictly manage worsening ascites, but failed to adjust to spironolactone. So we are clearly looking at an acute encephalopathic crisis. What is the precise pathophysiological trigger of his current decompensation?
Under exam conditions, you're going to be presented with a highly competitive option matrix designed to aggressively tempt you with distractor therapies. Let's look at the options. Option 1, inadequate acidification of the colonic lumen. Option 2, overgrowth of urea-producing gut flora. Option 3, amplified renal ammoniogenesis via intracellular potassium depletion. Option 4, microvascular portosystemic shunting. And option 5, spontaneous bacterial peritonitis. Because his ammonia is high and he's confused, the immediate temptation is to select a gut-directed mechanism, leaning heavily into the standard lactulose or rifaximin pathways. But as a high-level consultant, you must look deeper at the masked, iatrogenic metabolic precipitant hidden right there in his history. Let's execute a rapid assessment on these choices. Options 1 and 2 target gut therapies. Sure, they are foundational, but they aren't the acute trigger here. Option 4 is just his chronic baseline, and option 5, SBP, lacks any real infectious clinical signs. You actually have to bypass the gut entirely. The correct answer is option 3. By aggressively doubling furosemide without adjusting the spironolactone, the physician drove severe intracellular potassium depletion and metabolic alkalosis. This alkalosis strictly shifts stable NH4+ right back into toxic NH3, while that severe hypokalemia directly accelerates renal ammonia production. Furosemide was the masked trigger causing the astrocytic swelling. It really highlights the hallmark of clinical mastery. The final question you always have to ask yourself is this: when treating one failing system, are your interventions silently collapsing another?